straightforward, why I've lent on clinical advice from people far more qualified than us to make these decisions, but this is not easy. And it is not a comfortable decision, and it's one that I wrestle with on a daily basis.
Thank you very much. So I need to move on to scandals. So it's linked, of course, to the merger that we're seeing between DHSE and the department. First question, very simple. Are we ever going to get an answer to the Hughes report, Secretary of State? It's been 2 years.
Yes, yes, you
when?
are. We are working with our colleagues at the Cabinet Office to address what are a whole number of issues, from the Hughes report through to obviously work on infected blood is now well underway, but we've got other issues. I think particularly about the vaccine injured community. There are a whole bunch of patient groups who have been failed by the NHS
which
historically.
Is what I'm trying to come to the part of this, and as you'll know, many, particularly those who were suffering from Primados, which was a historic injustice, not yet recognised, in fact, I think, by the department as being the injustice that the victims describe it as, but there are many others. The reason I'm specifically asking about the Hughes report is because that was the beginning of the process.
Yeah, no, I appreciate that. So we've committed to progress on initiatives to improve clinical service provision before the 2nd anniversary. We are beginning to see progress already on both sodium valproate, on pelvic mesh, but in terms of broader redress, I'd kind of put this under the same category as a number of other patient groups that we're dealing with, where there is a cost attached to it. There are choices to be made across government, and we're working with colleagues in Cabinet Office in particular to make sure we have a consistent approach to remedying these sorts of injustices.
They do have a lot in common, don't they? I mean, there's sort of three broad areas. One is patients feel unheard, which is often where the problems begin. They also want it never to happen again, and they want investigations to happen in a timely way where recommendations are actually implemented. And then the third part is the redress scheme. So once those have been established, which they often are, they then have to fight all over again to get any kind of compensation beyond a mealy-mouthed apology, which frankly doesn't do it for them.
I couldn't agree more.
Would you agree that those are the three main areas? And is the idea to link those up? Because at the moment they're just not, are they?
Yes, and it's, to be honest, it is the third issue of redress that so often causes the hold-up. The reasons for hold-up are more often than not financial. The reasons for hold-up is because responsibility sits across different government departments. I say this by way of explanation rather than excuse, as you can probably
It's also fair to say, right, like we spent, what was it, £3.1 billion on clinical negligence claims in a single year. Some of that money could be diverted if the other three parts of the system were working well. And I do have a question actually for Samantha, because so part of the Dash Review's recommendations is that Health Watch will sit under you. Now that has raised concerns. You'll have been written to by, I think it was 138 local Health Watch providers who point out that at the moment Health Watch is completely independent, and that is one of its strengths, because people who do not trust the government and people who do not trust the NHS, quite often because they've been failed, feel that there is somewhere completely separate that they can go where their voices will be heard. So while you did answer Secretary of State to their letter, and much of what you have said they agree with, it should be closer, patient voice needs to be embedded, I don't think anyone disagrees with those principles, but you didn't at all address the point about independence. And so my question to Samantha, given that you are the one who is going to be running this as part of your department, how are you going to ensure, if that is the way you are going to go, that it's going to maintain its independence? Because that's the point I don't feel has been bottomed out yet.
Thank you. I think Dr. Dash's review was very clear in terms of perhaps more of a cluttered landscape around patient safety, and being very clear about who is accountable for patient safety and who is accountable for regulation, and ensuring that there is an independent mirror held up. So we have, of course, the CQC, for example, as an example of that. As we design the future Department of Health and Social Care, which we're in the middle, well, not in the middle, we're starting to do now, we have a very clear requirement to ensure that the patient voice and the independence of the patient voice is incorporated in our approach to patient safety as we move forward. And I'm very happy to come back to the committee as we progress over the next year with more details to demonstrate how that independence is happening in practice.
Work in progress, but there's another area that the independence of which is also being questioned. That's the point of investigations. So you'll be aware the HSSIB was set up following the aviation model. It's only relatively nascent. It's only really only just started. But again, as part of that review, the plan is for that to be sitting under the governance of the CQC. Yep. Yeah. You'll understand people who are concerned, and I share that concern personally, that if it's sitting under the same governance, how can we be assured that it is, again, completely independent? In the aviation industry, it is completely independent. And as by way of example, the HSIB, its predecessor that wasn't on statutory footing, did criticise the CQC as part of its investigations. Now, investigation is not regulation. The two are not the same thing. Regulation is meant to stop things from happening in the first place. Investigation is what happens after there's been an issue. How can you be assured completely that by having the HSSIB sitting under the CQC, that there isn't going to be inadvertent conflicts of interest?
Well, firstly, the thing to say is we are not going to incorporate HSIB into the CQC until the CQC is in a fit state to receive it.
Yes, quite.
And secondly, we will make sure through the sort of the governance arrangements and accountabilities that we do not lose that sharp focus on investigation and the expertise that HSIB has that I'm determined to protect.
But do you understand the issue about the independence again? So it's you didn't actually answer that.
But the CQC is independent and is the independent regulator. But it needs to be
independent of all parts of the system, because if the CQC itself is the problem, which as you kind of point out, at points it has been, then how can we be assured that the investigative arm isn't in conflict with one of the arms that it should be investigating?
Sorry.
Samantha?
We are very well versed, as you will appreciate, within the Department of Health and Social Care, of having inquiries and independent inquiries who are part of and separate to the delivery and the oversight of care. So your point is absolutely well and truly understood. Mm-hmm. We are very, as Secretary of State said, CQC is independent, and we will ensure that how we run inquiries, for example, within the department, is also in terms of the lessons that the CQC have, making sure there is the independence, which is the point that you are making.
HSIB is not the same as inquiries that are under the 2005 Act, are they?
No, I was more using it as an example as to how we can do both things that we do at the moment in the department. We will ensure that is the case within the CQC. It was an example rather than...
I mean, the principle here is that there are tons of checkers in this system. We need a few more doers, and we want to kind of streamline to make sure that we've got the right people doing the right jobs and diverting as much resource to the front line as possible.
Thank you. Ben Coleman.
Yes, thank you, Chair. I'd like to move on to a different area, which is mostly going to involve questions, I think, to give Wes a break, to Sir Jim and to Samantha, which would be about PFI and also public-private partnerships. The plan is to build 250 neighbourhood health centres, I understand, 120 operational by 2030, vast majority via a new PPP model and costing around £1 billion. Of course, we had a lot of money spent on buildings built both for health services and other services with the private sector in the past on the old PFI model. And I'm very interested in getting an understanding of what we've learned from what went wrong before. Mm-hmm. So my question is, can you set out what you in the department, NHSC and Department of have learned from what went wrong with PFI? Because if you reassure me on that point, then I'll feel much better about the next stage as you take things forward to the PPPs?
Want me to start?
Yes.
Yeah. We're all keen to avoid repeating the problems of the past. So the model that's being developed through discussions with Treasury.
Stop you right there.
Yeah.
I thought you'd say that.
Sorry?
I thought you stopped right there because
Well,
I thought you'd say that. I'm not going to ask you about them. I'm not going to ask you about the model. I'd like to go one step back. What were the problems that you found with the PFI that the new model is trying to? But if you could start with the problems, and then we could talk about how the new model would address those. Would that be okay?
Model, yeah. If you don't interrupt me again, I'll try and explain it. So in the old model, there were problems with the overall cost of borrowing, the way risk was managed, and the way swaps worked in all of that. The actual risk transfer versus perceived risk transfer, and how that was conducted in the model as well, and then also the cost of variations, how hard it was to change anything, and then for some schemes, because the model changed over time, the way the asset came back into NHS use at the end, or ownership at the end, at the point of termination. All of these things are being addressed in that model.
Are there other problems that you have come across? I mean, I think you've left something significant out, but I don't want to lead you. So I just want to get your view on what else was a big problem, has been a big problem. Samantha, I can see you want to come in.
No, I mean, Jim and I are as one on this. So the important point around this is that it's not bringing back PFI.
Okay, no, I'm just focusing on the problems that you
understand. We both had experience of that in practice. So the new PPP model is being led by NISTA, which is independent and co-designed by us for the reason, if I may, around more transparent payment mechanisms, greater contract flexibility to accommodate the change, and stronger monitoring in terms of robust maintenance of the actual asset conditions. So, and the reason I say that in the answer to your question is because those refer to what we would like to do differently in the future rather than.
I may ask you, have you both read the White Fraser report, I presume? Have you read the White Fraser report? No? Okay, well that's possibly the most comprehensive report on what went wrong with PFI. It's only 2 years old, July 2023. I don't see how anybody can take forward what's going on without learning properly from the past. And the number one, and it identifies the problems that you've identified, but the number one problem it identifies, which was obvious from the beginning, is civil servants' skills. The skills that civil servants needed to negotiate contracts were lacking, and the skills that the civil servants needed, the public service needed, to manage the contracts were woefully lacking. And it's partly to do with a completely different mindset, being in the public sector and the commercial sector. I've seen it in local councils. They talk about partnership. And you recognise the fact that the risk balance is often wrong, because partnership means when both sides take risk. But there's not just that. There's the ability to have negotiating skills, to understand negotiating incentives, leverage, what's agreed. Have you recognised the need to change the skill set of the public sector if we're going to do £1 billion worth of PPP deals?
My reference to NISTA was for precisely that point, which is developing these schemes, negotiating these schemes require, as you rightly say, a different skill set, which is why private sector expertise is being harnessed through the NISTA programme and the development in the future to ensure that those people who are designing those schemes and responsible for the negotiation of them take skill sets from lots of different places, which is why I was referencing NISTA. So it is taking that into account. It is a very different skill set.
So are you saying that we're getting private sector people in to train up the civil servants in negotiating, or are we going to be doing what we previously did, was effectively took advice from the private sector all the time while we negotiated, and inevitably they will be acting in different fora for the very people we're negotiating with? So are you training up, are you raising the skills of the civil servants so they're able to do this on their own, or are you going to be using lots of lawyers and people from outside to be alongside them?
I think the model that's being developed by NISTA, supported by us, will actually build on the lessons from the past, including a mixture of both people from outside of the civil service, outside of the NHS, working alongside commercial. And so I'm very happy to come back as it is developed over the next year or so in terms of what does that look like and what is the skill set and how does it actually work together as we go through. I'm very happy to do so.
Just I think my other observation is that in the time that's passed since PFI was introduced, the skills and capability of the system have changed, and there are probably, I suspect we can go back and check, but there will be more people in commercial functions now in the department and in NHS England than there were before, so we want to bring those together. And also, and in the spirit of, you're right, Ben, to make sure that we do not repeat past mistakes. At the same time, even today and in recent years, we have seen private investment models, whether that's lift schemes in England or whether that's a mutual investment model in Wales, which have passed without controversy, which have not hit the headlines, and have not seen people with placards outside saying no to lift or no to MIM because it's gone well.
But it's gone well. Isn't there a difference between, it's a very important point you make, and I appreciate you making it, and I felt you might. Isn't there a big difference between building something on time, which is meeting a political imperative, and seeing over the years to come what happens, whether there are problems, how they are dealt with, whether the civil servants have actually contracted effectively, whether we end up paying 100% more than we expected to pay? Isn't it too soon? We can judge MIMS and LIFT, yes, they delivered the projects on time, but we can't judge whether they were a success over decades, the way we have now been able to do with the PFI.
So I think in terms of how we're thinking about particularly the PPPs on neighbourhood health, there are definitely things at the forefront of our mind. One is making sure you've got simple and transparent payment mechanisms. The other is making sure that contract flexibility is built in to make sure we've got accommodation changes. And then also the monitoring to make sure we've got robust maintenance of asset conditions, and to make sure that, unlike some other models, the state has the asset. The other good thing, and this is the nicest thing I'll say about the Treasury today, the other good thing about the way the Treasury has set up the approach we're taking to the financing of neighbourhood health is that they have chosen to do public investment in this project alongside the private investment model, so that we can, in real time, look with a like-for-like comparison at what's been most effective. Has one been more cost-effective than the other? Has one developed better quality than the other? Has one been better maintained than the other?
That requires quite a lot of time, and the pressure on building 120 and getting them operational by 2030.
Yeah, we do it, that's why you do it in real time, Ben. And I think having that kind of approach is the right way of thinking about it.
Are you aware of an example where we would have looked at, because I think there's great strength in somebody starting to negotiate and just saying, no, we can't negotiate. You're asking too much, walking away from it, and the government, is there a danger, civil servants would feel under so much time pressure that they might not be prepared to walk away or close down projects?
Absolutely not. No, absolutely not. So I think it may be worth just a separate session on this. I think we are in substance in the project.
We're doing an entire inquiry on NHS estates that we launched on Friday.
So we're dealing with all of those issues. Well, just one thing. So I've signed off PFIs and bought one back. So I've learned a lot over the years through those processes. The evidence does, though, suggest that PFI schemes in the NHS generally produce better maintained assets in the long term. So they have generally outperformed the NHS.
If you spent the same amount on the, I mean, forgive me for coming back on that, but if you had spent the same amount of money as a PFI scheme cost to maintain,
there's a long answer to that.
Simply within the public sector, within public sector, if you'd actually been able to make the money available to keep hospitals properly maintained over a number of years, that would be the comparator that you'd need to use. I think it's a wholly unjustifiable statement to make. My last very quick question: are ICBs going to be negotiating and managing these contracts?
Yes or no?
The PPPs, are they going to be negotiated and managed by ICBs, and if so, will they be trained?
Not in my view, no. They'll be.
Sorry, we need to move on. Danny Beals.
Thank you very much.
Thank you, Secretary of State. In our 1,000 Critical Days inquiry earlier this year, we looked at one aspect around vaccinations in infancy. These remain below national coverage goals. There's significant disparities by region and by demographic group, which don't seem to be closing. Coverage of preschool immunisations has been declining since 2012, and rates in the UK are lower than Japan, France, Australia, Germany and Denmark. 2023-24 found that coverage had decreased in 14 vaccine coverage measures, and no measures met the WHO 95% target, which used to be an NHS target but was removed from planning guidance in 2025-2026. What's going wrong?
It's a mixed picture on vaccination.
That doesn't sound very mixed. It sounds quite...
Well, look, if we take where we've been ahead of this winter, so we delivered over 17 million flu vaccines for this season, which is 170,000 more than this time last year. 60,000 more NHS staff than last year are also getting their jab. We're on track to deliver the 5 percentage point increase in flu vaccine uptake in healthcare workers, which we set out in our urgent and emergency care plan. On school immunisation, the levels are broadly the same as they were last year and slightly better in some cases, and schools with low uptake will be followed up by second visits this week before schools break for Christmas. On the RSV vaccine, almost 68% of 75 to 79-year-olds have been protected against RSV, and we're on track to deliver the 70% target by the end of March as set out in the UEC plan. On the 2,500 more GPs and the modernised GP appointment bookings are helping with that, but there's more to do. So,
I mean, you describe some positives. I mean, some of those statistics are quite low metrics, well below kind of 95%.
Oh, look, I mean, just on that, Danny, look, just to put all of those positive numbers in context, we are not back to where we were in terms of pre-pandemic levels, and that is the kind of the initial bar we've got to set ourselves. So, I kind of report progress without wanting to sound defensive or complacent, because your central challenge is absolutely the right one.
The government restate the 95% vaccine uptake rate and planning guidance. Was it right to remove that target, bearing in mind where we are and where we've slipped to?
Well, I think regardless of whether it is in the medium-term planning framework, we need to give this the specific focus it requires and make sure that we've got resourcing, because in health visiting numbers, for example, we've seen a 45% decrease over the best part of a decade, and those sorts of things do have an impact. What we are doing is to make sure we're improving, is starting in those areas and with those patient groups where we have the biggest challenge. So the 12 pilots we're running with health visitors from mid-January will be with families who have the most barriers, including everything from ability to travel, language difficulties, vaccine hesitancy.
The pilots are very positive, and we heard the real role of health visiting. I guess we also heard that those pilots are quite slow. Sort of very few areas, potentially take another 12 months, if not longer, in terms of reaching kind of national level impact. Just you rightly mentioned resourcing. A parliamentary question that responded to yesterday about NHS England's spend on vaccine and immunisation programmes suggested that NHS England spent in 2021 1% of its budget on immunisation. That fell to 0.64% in 2022 and 0.5% in 2023. And if the overall budget has gone up, and maybe one might challenge the percentages, in real terms it fell from almost 1.5 billion on vaccinations in 2021 to 989 million in 2022, 850 million in 2023. That's lower in percentage and real terms than 2020, 2021. Do these drops in spending on vaccination programmes concern you?
Let me go away with Ashley Dalton and really kick the tyres on all of that, because on one hand, particularly when you spell out not in percentage terms but in actual spend terms, that for me says we need to take a good look, because I would expect across a whole range of areas that with the emphasis we're putting on productivity and modernisation, we would want to see greater efficiency and therefore not always higher spending. The tragedy of the NHS is that it's had higher spending spending and delivered poorer outcomes.
We are seeing more and more vaccines through scientific advances.
And we've got the new MMRV vaccine, which means from January, the MMR vaccine will include chickenpox for the first time. So there are lots of positive developments, and that could also point to why there are therefore savings if you've got more conditions and confined to a single dose, for example. But I will go and kick the tyres on that, because I think that is a fair question and a fair challenge to ask us.
I welcome that, Secretary. Thank you. And as part of kicking the tyres, I guess we've just outlined that. So we've seen falling spend, we've seen falling rates in many categories of vaccination. More outbreaks has been reported in the press amongst children. One might say that points that the 2023 NHS England vaccination strategy has not worked. Unless it predicted, and that was the strategy, which I hoped it wasn't. No. So as part of kicking the tyres, I hope we might consider updating the national strategy for vaccination.
I think you ask a fair set of questions, and we'll go away and look at that in detail and come back to
Another issue the committee looked at this year was dentistry, and there was big announcements yesterday about kind of overhauling the dentistry system, described as a major overhaul, and certainly there were very welcome changes in there around prioritising the patients most at need. Obviously the sector, particularly when we spoke to them earlier this year, wanted the UDA looked at the cap on the amount of activity that dentists could do changed. It doesn't seem those were in the announcements yesterday. Just in terms of what these announcements mean, is your sense that this is the end of dentistry reform in this Parliament, or is there more to come?
No, it's definitely not the end. This is part of it. What I want to see is consistent improvement in the quality and availability of NHS dentistry over time. We are starting from such a low bar. And even on our manifesto commitment to deliver 700,000 urgent emergency dentistry appointments, money has been available. ICBs have been making extra appointments available since the 1st of April this year. They're available across the country, but the rollout of that has not been going as fast as I would like and Stephen Kinnock would like, and we are giving that a real push into the new year. So I think the system we inherited in dentistry is, of all of the parts of the NHS, the one that starts, I think, from the worst starting point that we would have wanted. You know, we're stretching, even by kind of usual standards of, well, I wouldn't have started from here. We are kind of stretching. But what I was really struck by yesterday with Stephen's announcement was the welcome it got from the British Dental Association as well, who I have to say, to be fair to the BDA, have had patience of saints. They've worked with us really constructively. They understand the pressures we're under, and they've always, when they've challenged us privately as well as publicly, they've always done so constructively, and I really appreciate that.
Thank you. I would certainly associate myself with that comment about the BDA. Just finally, and it's welcome that there'll be further opportunities to reform dentistry. And you're right about the terrible state that this government inherited dentistry in. Has the final financial envelope for dentistry now been set following the spending reviews? When we saw the Minister previously, it was still under discussion. And if so, is the spending allocation on dentistry bigger, the same, or smaller?
Well, we are currently doing financial planning with the system as we speak as part of the medium-term planning framework. We're getting returns from across the system back now. That will help to inform where we are on investment in dentistry, and no doubt when Jim next come back to the committee, because Sam and I didn't make that commitment. When Jim's back, you can ask him. Thank you.
Thank you very much. Paulette Hamilton.
Oh, thank you. I just want to ask one small question around dentistry. The contract has always been the main issue. What is being done to address the contract that has been the problem from day one?
So part of what Stephen announced yesterday is embedding urgent care into the contract, but I think we're realistic that contract reform is going to be an ongoing process. And look, there are lots of, you've heard me say before, there are lots of problems in the NHS which are not about money and are about modernisation and getting more bang for the buck that's going in and changing the way we do things. in dentistry, I would accept that this is also a money challenge as well. And we're going as hard and fast as we can with the resources that we have, and recognising that we've done relatively well out of the Treasury compared to other government departments, and the Treasury is doing as much as they can given the personal priority the Chancellor attaches to the NHS. But even within that constraint, we are not able to spend our way out of the challenge as quickly as we would like.
Thank you, Wes. Right, now my substantive question is around winter pressures. Now, I always ask about this, so I might bring Jim in to give you time to get some water. Wes, regarding winter pressures, the NHS has been preparing for winter pressures even earlier when we had reports come to the committee than even last year. In your plans, how have your plans for this year been changed based on your experience from previous years? So even though we've prepared earlier, the plans you've looked at, you've tried to change, what has actually changed? Because we're still having this major problem this time of the year.
Yeah. First of all, there's a point about what's the future of urgent care? How does the NHS manage winters routinely without having this big sort of pressure every year? And I think we're going to take some time early in the new year, as soon as we can after peak winter, to try and get our plans together about what this should look like in the future. So we'll get out of this habit of accepting that it's a terrible drama for a couple of months over winter, and it's sort of baked into how we'll work. So first point, we'll come back at a point in time when we're able to talk about that more fully. This year, it's been much more locally driven, so less kind of central control and submissions, etc. So the national team working with local colleagues in the summer to start thinking about what the plans look like, and materially, on your point, anticipating where there would be problems and getting ahead of, so what would you do then? What happens then when place A falls over, when ambulance handovers stretch out to a certain point, when Cat 2 response runs out to a certain point? Actually, what happens? Who's going to do what when? And using that, rather than trying to work it out at the time when everybody's stretched, everybody's under pressure, anticipate it, get the plans more robustly in place to do that. There's also, we've been working on trying to make the service more consistent in places, using models that work in certain places, and we've got a bit of work going with the College of Emergency Medicine, some chief exec colleagues in Society of Acute Medicine, to create a kind of model for the front door. So again, help everybody understand what works, and over time make sure every system has what normally works.
So are you hoping to learn from the mistakes that were made? And I'm not saying mistakes have been made, but from some of the issues that you faced both last year and this year, because could it be that working just on a local basis isn't enough, and it has to be driven more centrally?
Absolutely, and we've got a lot of work to do to make sure that people understand what works in place X. That's a long way from place Y, and then that be adopted more. You know, how does everybody understand what a standard model should be? There's some judgments in that from our point of view about where we should allow people to work out the local nuance versus where we say this is just how it has to happen everywhere. It works, we know it works, everybody just do it. Commissioners need to commission on that basis. And then also, Paulette, you'll have seen all this stuff in recent weeks about flu and the pressure. We've actually had our first contact with winter in a pretty nasty way over the last month. So 2 weeks ago, I really worried about what I was doing, the way flu was accelerating, the pressure in certain systems. That looks like it might be starting to settle, still early days, but might be starting to settle in some parts of the country. And the way the service has held on to handover performance and Cat 2 performance especially, which has been the main focus for the NHS over recent years, I think does give us heart that we've been able to learn from last year and make some adjustments.
I'm going to have to stop you. I've got 1 minute and I need to get this in. It's about vaccine hesitancy. I was a nurse for many, many years, as everybody knows. But the big issue is around the health professionals, allied professionals and others that are not taking the vaccines. Has the time come where everybody needs to wear masks to protect patients? Can I ask Wes to just answer that quickly?
No, the time has not yet come for everyone to wear masks. But what we are absolutely supporting frontline leaders to do is to determine whether, given the pressures they are under, whether it's the right thing to do to ask visitors to hospitals or other NHS or care settings to wear masks to protect themselves and others. There will be places where that's happening. It will be done in an informed way, on the basis of the conditions they're operating under, and most people will happily comply with that. But at this stage, there's no need to kind of mandate mask wearing or to ask everyone around the country to do the same.
Thank you. I'll hand back to the
Last
chair.
questions, Greg Stafford.
Thank you very much, Chair. And I've got 3 questions, hopefully they're brief, so hopefully brief answers as well. So the first is, as far as I'm aware, the government is yet to publish any timescale or scope for the health bill. So when will the bill be published?
In 2026, certainly.
Can it be a little bit more specific, Secretary of State?
Yes and no, because this is not just my decision, it's subject to the agreement of business managers, but suffice to say we're working at pace to make sure the bill is ready, and certainly to make sure that we can complete the abolition of NHS England within the timetable set out by the Prime Minister.
Okay, so spring?
In 2026.
Not massively helpful. In which case, let's move on to funding. So is the department on track to eliminate deficit support funding in 26-27, given that 92 trusts are still in deficit?
So medium-term plans will tell us how far apart we are when we get them, and how we're developing over recent weeks. We won't have eliminated deficit support funding, but we've set up the system so that everybody knows what the rules are. We want to wean off it over time. I think it's unreasonable to expect to get to nil next year or even the year after, but we should see material reductions, and we've seen material improvements in this year so far.
Okay, so essentially that target's been scrapped.
It hasn't been scrapped, no.
But if we're not going to make it in the timetable that you've said.
We set out an objective, and we're making progress against that.
Final question then. Secretary of State, you stated very recently, I think it was earlier this month even, that you will not cut NHS budgets to fund the pharma deal. Can you set out how you are going to fund that then?
The bill is not clear. It is extremely complicated, the way that VPAG works and the way in which the rebate is calculated. So companies have to pay the government a rebate of a proportion of their sales, with the revenue distributed to the NHS across the UK. For newer medicines, the rebate rate is set each year at a level calculated to sales to an allowed rate of growth. Under the US deal, the rebate rate for newer medicines will be capped at 15%.
So sorry, forgive me, because I don't have much time. Where is the money going to come from?
Well, we don't know what the cost is going to be.
Yes, but you must have some idea, Secretary of State, and you must have some idea of where that money is going to come from when you have to spend it.
Well, when the Treasury made their allocation to my department in the spending review, they took into account VPAG costs. So if the costs arrive within that envelope, we're absolutely fine. If we're without that envelope, then both within my department and across government, we manage that in the usual way.
So you will cut NHS budgets?
Nope, we're not going to cut.
If the money's going to come from the department,
services.
Where's it going to come from then?
The department has budgets for a wide range of things, including contingencies, and we've also been funded to a degree on VPAG as well. So the challenges, and I'm not trying to be difficult in answering your question, there is just such a wide range of variables in terms of what the number will be, and when that number and the highest plausible number would materialise, which may even be outside of the spending review period. So that's why I am firstly absolutely confident in saying we will not cut NHS budgets to fund this. Secondly, we have been funded by the Treasury, taking into account these costs. And thirdly, should the costs materialise at a scale and at a pace which is unexpected, then we manage those pressures in the usual way, which is either within the department's budget, if we're able to absorb those costs. Where we're not able to absorb costs, of course, we talk to our good friends at the Treasury.
Can I just one final point of clarification? You said you wouldn't cut NHS budgets. Can you confirm you wouldn't cut social care budgets as well?
Yes, we're not interested in cutting frontline services to fund the US Pharma deal, which I have to say, by the way, is a deal that also delivered a 0% tariff for pharma exports for 3 years, and I think has achieved a really good outcome given the pressures and constraints that the negotiating team were operating under.
Thank you very much. We also thank you for your extra time. We enjoyed that together. Order.